Hi, this is Brian Kim. I'm going to share with you case number 207, the best way to do cataract surgery series. This patient has a strong Bell's reflex, and you're going to see I'm going to try my best to control the eye without grabbing the eye, but you'll see in certain parts I just have no choice because this patient has such a strong Bell's reflex. You're going to see my techniques and how I handle that to minimize grabbing the eye. Also, you're going to see double chop, cross chop mechanical fracturing techniques, and this is going to be a Panoptix trifocal lens implant. So you can see this patient has a terribly strong Bell's reflex. This is the right eye. I'm using the cotton tip to try to turn the eye down, and I use a corneal marker to help me center and size the rexus. And then I make my paracentesis incision first on the right side and then the left side. Of course, the right side incision is super easy to do because the patient's belling up towards the left side of the screen, but it's going to be really hard to make my left side incision. I'm using a cotton tip to turn the eye down. This patient refuses to do that. And, of course, I'm asking the patient to do it. They just can't. And so I'm going to use forceps to turn the eye down. But look at how I grab the eye. I place the tooth inside the incision, and doing it that way, I'm not grabbing the cornea, I'm grabbing the sclera. So by turning it down with that forceps, I'm able to inject some intracameral epinephrine. And while I'm holding the eye, I'm injecting some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. You can see the patient has a focal area of loose epithelium, and most likely we'll put a bandage contact lens at the end of the case. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And I'm going to keep that cannula in the eye to control this eye because this patient's going to bell up immediately as I let go of my paracentesis incision. So the paracentesis incision is acting like an oarlock, but I'm leveraging that oarlock to my advantage so I can control the eye without having to grab it. These are the Moria microforceps. I puncture the center and pull down towards me. With the teeth closed, I can use it like a cystotome and then grabbing the right side of the tear, going around circumferentially. And if the chamber starts to collapse, I can always push some more viscoelastic in. But again, with these forceps, you have very good chamber control. Grabbing every other clock hour essentially here. Finishing off the rexus, burping viscoelastic out. And this is the capsule fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally, point the tip down, get a nice wave, lifting the lens up, decompressing the bag. It's hard to sweep on the left side. I go ahead and sweep on the right side, and the lens begins to spin, fortunately. This patient's squeezing so much and a lot of oils are coming out from the meibomian glands. So you can see I'm irrigating quite a bit. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Using the chopper, I'm able to control the eye one more time here. Removing the surface epinuclear material, placing the chopper under the rexus edge contra-incisionally, pointed it down. Turn the phaco tip vertically sub-incisionally, fracturing the lens completely in half. You can see there's no translational movement of the lens. I'm able to fracture the lens without causing any stress on the zonules. Placing the chopper around the right heminucleus, hooking the peripheral lens, crushing the lens in half against the phaco tip, and that is the cross chop. Placing the chopper around that first quadrant, hooking the peripheral lens, crushing it in half, and then crushing the lens with opposing forces, and then emulsifying the lens pieces. Again, when I'm fracturing the lens, I'm not using ultrasonic energy or vacuum. By doing it this way, this reduces ultrasonic energy use. This also reduces the chance and potential of removing the OVD that's coating the corneal endothelium, which can undermine my ability to have a clear cornea after surgery. Lifting that second fragment up, crushing the lens between the instruments and emulsifying the lens pieces. Turning the second heminucleus in front of me, using some vacuum to lift it up, getting around it with the chopper, hooking the peripheral lens and crushing it in half, and then crushing that third quadrant in multiple pieces between the instruments, and then emulsifying the lens pieces. When you know that you're deep in the bag and you're holding the lens with vacuum, that's perfectly fine. And again, I have bevel down, so because I'm bevel down, I'm not orienting the vacuum towards the corneal endothelium. So the chances that I'm going to cause the viscoelastic that's used so the chances of removing the viscoelastic that's coating the corneal endothelium is much lower because of this technique. Removing the epinuchal material now, keeping the chopper deep. Always keeping that chopper deep to protect the posterior capsule. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the eye and handpiece. It's very important to have two instruments to control the eye in those moments. Otherwise, this patient's going to bell right up, and it's going to be hard to control the eye. Switching immediately to polish mode, polishing under the rexus edge because the bag's relatively clean. You can see some fine cortical wisps there. I'm going to try to remove them. Polishing the posterior capsule some as well here. Polishing the subincisional area. If you're not really careful, you can miss those fine wisps. There's quite a bit of material that's in the subincisional area adherent to the posterior capsule. So now using the BSS cannula, I'm going to pulse into the subincisional capsule fornix, and let's see what happens. Yeah, you see quite a bit of stuff coming out. And then I'm able to loosen it up and then remove it with the eye and handpiece. Turning irrigation off and then pushing cohesive viscoelastic to fill the bag. I'm going to keep that cannula in the eye because it helps control the eye since the patient has that strong Bell's reflex. I'm using that sweep to remove some of that incarcerated lens material that's in the subincisional area. Polishing on the right side now. You can see there's quite a bit of pooling of fluid throughout this entire case. But it really doesn't affect what I'm doing because of my techniques. I'm going to place the single piece acrylic lens into the capsular bag. Going in with irrigation off, activating irrigation, making sure both haptics are within the bag. Because I have to orient the toricity, I decide to go under it from the left side, tilting the lens, removing all the viscoelastic from within the bag. And I believe this lens is going to be like at around 15 degrees or something like that. Polishing underneath the rexus edge. Going to low mag, this helps with the alignment in my experience. Going to visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. You're going to see as I hydrate my incisions, again, I'm trying to orient the lens and get it in general position with the INA handpiece in the eye. By doing it that way, you're able to inflate the capsular bag and you're able to rotate the lens either clockwise or counterclockwise, whichever way you want. And you can do that safely because the lens is not being held or tethered by the posterior capsule or the capsular by the capsular bag. And by inflating the bag like that, it's not going to be touching the lens, and therefore it should be able to turn quite easily. The main way of locking the lens into position is really when you let the chamber collapse, and then the lens is going to be held by the capsular bag as the capsular bag collapses. So you come out with irrigation and then quickly hydrate the incisions. And another thing is, I think it's very important not to overinflate the bag at this point. If you overinflate the bag and you're not careful, that's when the lens can rotate, I believe. And I do think there's certain risk factors for that happening. Again, in my experience, I haven't had any very little. In my experience, I've had very few post-op rotations, and I think it's because of the way I do these cases. So again, it's about 15 degrees, making sure the lens is completely within the bag. I'm trying to get the pressure to physiologic. It's good pressure now. Get the ring into place, making sure that the axis is proper. So like I said, around 15 degrees, and that's perfect. And so again, this patient has strong Bell's reflex. I had to hold the eye with forceps, but I make sure I don't grab the cornea. When I do that, I want to put one of the teeth into the incision and make sure the other tooth is actually on the